Hello, welcome to the Orthopedics Hip Examination presentation. My name is Khalid Al-Awadi. I'm a final year medical student at Kuwait University. This presentation is intended for medical students in Kuwait University, clinical years, 5th year and 7th year. So these are my references for this presentation. So this is a disclaimer as mentioned earlier, this is intended for clinical year medical students in Kuwait University. So you have to adhere to your local medical school guidelines on examination and clinical skills in orthopedic surgery. I would like to thank the Standing Committee of Medical Education, including the clinical years subcommittee as part of the Kuwait Medical Students Association, KuMSA, for the contribution to this presentation, as they help medical students achieve and excel well in their studies. So let's begin. So start with the table of contents. So what we'll talk about in this presentation is a case scenario. Then we'll proceed to the examination scheme in orthopedics, and then we start with look, feel, move. Then we proceed check for a neurovascular status. Then we check also for special tests. Further, finally, we'll end the presentation with common questions you might be asked during this station. So we'll start with the case scenario. So you are an attendee, a doctor in a Razi hospital, and you were referred from another hospital to a Mr. A 30-year-old gentleman who works as a construction worker, presented to an emergency department with 1-day history with right hip pain after fall from height of more than 2 meters from a construction site downtown. So after you're taking a proper history, including history of pain, limbing, etc., please examine this patient in an orderly fashion according to his main complaint in 7 minutes. So this is what will be shown at the start of your station or prior to starting this station. Usually, sometimes they don't tell you the system required to examine, so they give you this vague presentation, and you have to figure out where the problem is to examine properly. So let's begin. For anatomy, you have to know your anatomy very well, as you'll be asked during or after examination, plus its clinical significance. So I advise to study the clinical examination booklet distributed from the Kuwait University Department of Surgery, as it's an excellent reference to study for the examination, as more and is sufficient to study the orthopedics examination. So let's begin. Examination setting. In every orthopedics setting, the always examination setting of starting with wipe, wash, introduce yourself, permission, exposure, look, feel, move, neurovascular status, and special tests. So these components are crucial in in orthopedic examination. So as we know, we always start with wipe, wash your hands, introduce yourself to the patient examiner, ask the patient for permission for examining his hip. So you'll say, you knock on the door before you enter the station, and you say hello. Sorry. So you knock on the door, you enter the examination room, you wash your hands, and then you introduce yourself to the patient and the examiner. You say, hello, my name is Khalid Awali. I am a final year medical student. I'm going to perform the hip examination, which involves examining your hip joint. Is that okay? Exposure of the patient's leg while he is standing. And one more point I forgot to mention, always comment during orthopedics examination. Always comment, because you don't have enough time to tell your findings later on. So always comment what you will do in every step in a clear, orderly fashion manner, so the examiner can note where are you at. So start with look. We always look at two points: inspection and gait. So start first with inspection. So while the patient is standing, look at the legs from front, sides, and backs, from anterior, lateral, and posterior. So always, when you look at all these sides, always look for the scars. So a most common scars you will encounter in your rotations is total hip arthroplasty. It involves which is involve replacing the hip joints in case of osteoarthritis with a aluminum or a prosthetic joints. Another scars you may also encounter is the hip arthroscopy, which is basically uh, which is in which a small scars with a scope involves in repairing the labral tear, um, repairing the joints, the tendons involved in the hip joint in athletes. Finally, another scar you have to check in pediatric population is in cerebral palsy, which you will take in 6 years. That some of the patients they have contractures, which is um, meaning this muscle has been disused for a long time, or this because of the weakness at the nerve at that area, or because of improper physical rehab. And these type of patients, cerebral palsy, which is a shalal dimaghi, they put a scar to release that tendon in order to avoid any stiffness later on in that joint, avoiding recurring problems later on. Swelling. So an example of a swelling is a famous example of swelling we always see it is an osteoarthritis, and don't forget a hemarthrosis. It is seen in hematology medicine, but you see it mostly in the knee. Plus, in swelling is in hip joints difficult as is because of the bulk of the muscle, but always check for swellings. The posture. So as the patient is standing in his position, always check for joint position from hip, knee, and ankles. So what do I mean exactly? So when you look at the hip from front, is the hip flexed, extended, adducted, abducted, externally rotated, internally rotated? The knee, it is percurvatum or recurvatum. Is it internally or externally rotated of the hip? And the foot, is it in towing or out towing? And further examples are mentioned in the booklet, so refer to the booklet to read more examples. Skin skin changes, which is discoloration or pigmentation. An example of that of skin changes, as mentioned earlier, related to swelling in erythema, for example. Sinus is present. When you see a sinus, is most likely this patient may have a chronic osteomyelitis of that joint. Mostly you can, but you can't see it. You can't see it in the knee and the hip, and it's very very difficult to treat because of its chronicity. So, and another point that you should check is a muscle atrophy and wasting. So you check for gluteus muscles, the quadriceps, and adductors. But most you have to focus on in this patient is the gluteus wasting. So the gluteus is you have to check the muscle at the muscle itself. Is it having problems? The wasting in that area because of after surgery of total hip arthroplasty. As a common, you may injure the nerves involving the muscles of the gluteus muscles, which I'll ask later on. So another example of that are contractures and deformity. So a famous example of a hip flexion contracture. Why? So why we have a contracture? So hip flexion contracture. To define a hip flexion contracture means that this patient has lost the probable of doing a improbable full extension. So the patient has an angle, a missing angle of an inability to do a full extension at that point, which I'll mention it later on. And this is an example of a patient involving hip flexion contraction. This is an old picture. So this patient having a hip flexion contracture because of either the joint problem or a fracture, or because of a spine. As you know, in every anatomical structure, always refer to the one above. So examine joint above and below. This is a concept in orthopedic surgery. So as this patient having an exaggerated lordosis, so this patient having an exaggerated curve, so this patient having a problems in a flexion contracture. Then finally, looking for walking aids around the room, a wheelchair, a walker, a crutches, because this patient may have problems with walking, or he had recently did surgery, but he still requires time to fully weight bear. So this is so next we'll go to gait. So we'll start first with a normal gait. So let's say, so this is an example of how we ask to do gait. So we ask to do it for this patient to a normal gait from one end of the room to another, or going from that wall towards you, going back. Now, what if we abnormalities we might encounter during gait? And examples of that is, start first with the video on the left that will be shown normally. So this patient having a apologies, but this is a typo in the text. So patient having a circumduction hemiparesis, which is a neurological gait, we call it. You may encounter this during your OSCEs in medicine. So walking a half circle. He's walking with a half circle, his leg, because of the problems, because of the neurological problem, nerve affected on the left lower, the lower motor neuron lesion. Next is the shuffling gait, or we call it the Parkinson gait. So this is an example. If you want to check for Parkinson's features, you have to do this gait. And final example, which I'll skip through. This is what we may encounter it in orthopedic. So it's something called the high slippage gait, because of compensation of a condition like foot drop, which is involving the nerve, the deep peroneal nerve. If the deep peroneal nerve is affected, the patient won't be able to dorsiflex his foot and move his legs, his foot properly with the steppage. So he'll be like dragging his foot. Now this is an example of called a waddling gait. So this you see it more in pediatrics later on when you take a musculoskeletal chapter in pediatrics 6. So this patient has a waddling gait, which is means that the problem has Then this patient, the doctor will ask him to do a squat. Normally, when you do a squat, you'll kind of go back normally without the aid of another structures, because your knees and your foot and your legs are stable. Watch this patient who has waddling gait. What will happen? He's unable to squat properly. He will fall. Unable to squat properly. And he has to assist. Try to stand and push on his knees in order to stand properly because of the weakness in his proximal muscles. Another example is antalgic gait, which means pain during stance phase, which is the pain during movement. You see that most commonly in patients have disuse muscles, or let's say problems with pain after surgery, sometimes if not well anesthesia is given enough, this patient may have problems later on antalgic gait.
An antalgic gait refers to a painful limp. The patient's stance phase will be shortened on the affected side so as to limit the time and extent of weight bearing. Specific posturing depends on the affected area.
Now, the final example is something we'll talk about now. And this is very important gait, as you'll be asked during at the end of the station or during the station. This is called a Trendelberg gait pattern. As you notice, this patient, if I can go back again and play it, this patient has a pelvis is tilted to one side. Why? So we'll talk about it now. So why this patient is developing this condition? So the problem is that one of the muscles involved in that gait is one of the gluteus muscles, which we'll see now which muscle is involved exactly. So there is a difference between a gait and a sign. A gait is when you see the patient walking and it develops the gait. A sign is when you ask the patient, when you do the sign on him, the examination. So if I want to ask the patient to do a sign, so you have to do the test. You do the following. You sit on a chair, place both of your hands at the pelvis from the iliac crest on top, and ask the patient to stand one leg at a time. Normally, the patient, if he's able to stand, he will compensate with the muscle from the other side. So let's say the patient has standard one leg, and he flexes his leg, the other leg. The muscle at the standing leg will work because the pelvis is stabilized. It's pulling the muscle because of the gravity. Since he lifted that leg, the gravity will pull him downwards. So to avoid that, one of the gluteus muscles, which is the gluteus medius, will pull that muscle towards his side. Now, a positive test is, let's say this muscle has weakened or there's an injury to that nerve, which is the superior gluteal nerve. The pelvis will drop at the side of the lifted leg, which means the contralateral, not the same side, this is a very important, hip muscle, which is the gluteus medius, is affected. And this is a video again, showing the gait, and this is how you do the at start. So you put your hands above the iliac crest and you ask the patient to do the test, the sign. So again, which muscle is affected in this patient? The gluteus medius. One more thing I forgot to mention: the gluteus medius acts in hip abduction. So this is why the pelvis is unable the pelvis will not drop. If the pelvis drop, it means the hip abduction in that muscle will be affected. So a patient will have problems in abduction in that side. So before you finish your inspection, you ask the patient to lie in bed looking for leg length discrepancy. What does it mean, leg length discrepancy? It means the difference between two limbs. Is it identical? Is it different? So you have to check. There are two techniques or two reasons of LLD: true versus apparent, with the use of a measuring tape. We'll start first with a true LLD. So you measure, shown in this picture. So you start measuring the anterior superior iliac spine, and you measure all the way to the median malleolus, which is this area here, at the distal tip. And you measure on both legs. If both of them identical, it's normal. However, there's a short difference in this true method, so you have to check where's the problem. Is it because of a fracture? If yes, So you do a toe test, which is a tibial LLD. So the patient, you ask him to flex the knees, and the calcaneus bone should be as close as possible to the buttocks, and flex the knee as close as possible to the buttocks. If both of them are at the normal level, this is normal. However, as shown here in this picture, one is shorter than the other, means that the shorter leg has the problem, which is shown here, evident here. The apparent LLD, which means you measure from the umbilicus, this picture. So either measure from the umbilicus or from some of the books measure from the xiphoid sternum to the distal tip of the medial malleolus on both legs, and you measure. If not identical, this means the problem is with joint deformity, and you have to further investigate. So this is the end of the inspection. Now feel. When you palpate, always palpate on one side and compare. So what do we palpate exactly? So start with iliac crest, go from the iliac crest, then palpate for the anterior superior iliac spine, which is, then go below go distally, and you feel for the inferior iliac spine. Then at the middle of the pelvis, you feel for the pubic symphysis, or some people say I should go above the pubic hairline to palpate for the pubic symphysis. And finally, you check for greater trochanter of the femur. So how do you palpate it? So you palpate it as shown here in the picture. So next we'll start with move or range of motion. Always start with active, then passive. Make sure when you stabilize the pelvis with your hand on the contralateral pelvic side. Why? Because sometimes some of the patients who have problems or have pathologies will mask that sign with the pelvis movement. So he moves the limb in abduction and adduction. However, he's moving is assisted with his pelvis. So always make sure you stabilize it. So starting from the anterior superior spine, you push downwards of that other side and ask the patient to move his leg to the right, then to the left. Let's say I want to examine the right lower limb, abduction and adduction. You stabilize the left anterior superior iliac spine, the left pelvic side with your left hand. Then ask the patient to move an abduction and adduction. Then you do a passive movement of the abduction and adduction to see how extend the patient can have. Is it restricted or not? So for abduction and adduction, ask the patient to abduct his leg to the outside of the bed, then adducts his leg and cross over his other leg. يعني مثل ديوانية قاعد ريل على ريل. Flexion extension. So ask the patient to lie on his right side. So as a physician we say that lateral decupitous position. I pretend he's shooting a football with his leg. So starting with extension, so his leg going back, then flexion as he's shooting, going forward. Then we go to internal and external rotation, which is a very common mistake you may encounter during your exam. And I saw it during our OSCE review session. So when you ask the patient, you ask the candidate, how do you do external and internal rotation? The candidate thinks that the external and internal rotation is actually from the foot, not from the hip. Wrong. Consider that the tibia and the fibula from the knee downwards has been amputated, removed. So how do I know external and internal rotation? As shown here, this is the examiner or the doctor. He's stabilizing the pelvis on that side, and he's trying to rotate the leg externally. So this is external rotation. We are focusing on the femur. We're not focusing on the foot. So this is external rotation. The examiner is trying to internally rotate the femur. So this is internal rotation. So our aim again is the femur, not the leg. Our aim is the femur, not the leg. Next, we'll proceed to neurovascular status. For this step, you have to examine each nerve and its function. So, in neurological examination, as you do a neurologist examination in medicine, you do a sensory examination of every nerve involved. We start first with the start sensory, then you go to motor examination. So, how do you do motor examination? So, you examine against resistance. For femoral nerve, check for hip flexion and knee extension. For obturator nerve, hip adduction. For superior gluteal nerve, of its hip abduction, this is a common nerve you'll be asked during that station, to be careful. And inferior gluteal nerve, which is hip extension. And in vascular examination, always check for three arteries. The femoral artery, as you know from general surgery in hernia examination, palpate the femoral artery at the mid-inguinal point, which is the midway between the anterior superior iliac spine and the pubic symphysis. Then you palpate for the dorsalis pedis artery at lateral extensor hallucis longus tendon, or sometimes students prefer to say between the first and second metatarsal bone. However, it's ideal to say at the lateral to the extensor hallucis longus tendon. This is a very good medical way to say it. Finally, we palpate for the posterior tibialis artery, which is a midpoint between the calcaneus bone and the median malleolus, or 2 cm posterior and 2 cm distal to the median malleolus. And palpate. And always compare to the other side, don't forget that. So this is an example of the so to summarize, for the obturator nerve, if I want to know how do I know the obturator nerve function, the obturator nerve innervates the adductors, which means the hip abduction. As you can see, the obturator foramen is median. From it goes out the obturator nerve, so it's innervates the adductor. So it'll be easier. So remember, the obturator nerve is innervated adductors, so it does the function of the hip adduction. Again, the obturator foramen, since location, it will innervate the adductors. It will do hip adduction. This is for the femoral artery pulse. Again, so it's a mid-inguinal point between the anterior superior iliac spine and the pubic symphysis. Finally, so this is how you examine the dorsalis pedis artery and the posterior tibial artery locations. So this is how you do a hip flexion and knee extension. You ask the patient. So you ask the patient to lift his leg for the femoral nerve. This is for obturator nerve. This is a video, I'll show it. So the obturator foramen is a midline, so it comes towards the midline, so it adducts the leg. So I want the leg to adduct to the midline. This is how you examine against resistance.
Adductor, because the adductor's on a bit of length now. Squeeze in both legs. Squeeze. Okay, and then if you're going to feel it, more likely it's that one. If you want to put the muscle onto a little bit of stretch, okay, so from here, pull in now, slowly. Okay, and that might give you some discomfort. Or you put the leg, let the leg drop out. Okay, and then pull in now, and then that might give you some discomfort.
So basically,
so this is a summary. You have to memorize this table properly. This is from the booklet. You have to memorize every step, every nerve, from sensory, motor, and the muscles. And finally, we go to the special test. So for a special test of the hip, we're checking for 3 things: muscle contractures, muscle weakness, and pelvic instability. For muscle contractures, the first test is called KuMSA test, which is a tight iliopsoas sign, which I'll show you in the video now.
To perform the KuMSA test, have your patient in supine lying position and first check for excessive lumbulordosis, which is usually present with patients with a tight iliopsoas. Okay.
But make sure when you do this examination, always place your hand behind the back of the patient at the lumbar area, while I ask the patient to flex, because sometimes he can mask it with the lumbar. He can flex his he can hyperlordosis or loss of lordosis somehow to affect that area of that function.
To perform the Thomas test, present with patients with a tight iliopsoas.
And this test is affecting the tight iliopsoas.
Then ask your patient to bring his knee as far to the chest as possible and to hold it afterwards. And ask him if he can feel a stretch in the right groin. Okay. With a positive test, you will see that the extended leg is lifting off the table, like in this case. You can even measure the angle at the knee as a reference. Okay?
Next is the Uber test, which I'll show you here. So the Uber test checks for the IT band or iliotibial band for tightness. So the patient is placed in a lateral position with the affected side.
To perform the Thomas test, have your patient in supine.
So we're examining the Uber
To perform the Thomas test, have your patient in supine lying position.
So for the Uber test, have your patient placed in a lateral decapitous position with the affected side up. The hip is flexed. The hip is flexed as much as the hip is flexed at a flex, and then abducted a bit. Then extended as much as possibly as I can until he feels a stretch. Then you keep the foot in the air, and the patient, because of that stretch, he has to try to adduct his hip to avoid the stretch and the discomfort. A positive test is when the patient is unable to adduct his hip. So this is the Uber test. If unable to abduct his leg, always suspect a tight IT band. Finally is a tripod sign or a hamstring contracture or tightness. You always do it at the end of the bed. Sometimes in the station, the bed is so close to the wall, there won't be enough space to perform the tripod sign. So if you can, if not, try to move it to the other side of the bed and do the test. In the exam, you will ask to do one test of each section. So the muscle contracture has to do one test because of the time.
To perform the Thomas test, have your patient in supine. To perform the Thomas test.
So finally is a tripod sign, as shown here. So this is the patient at the end of the bed. He'll be asking the patient to passively, he will passively extend his leg and his knee. This is a normal stage. However, in a positive test, so he's passively the knee extension, and that shows you the positive sign. The positive sign, if the patient, because of the stress, he'll lean back to compensate for the discomfort and the hamstring tightness, the contractures, or curve his spine to compensate for that problem. The next section is muscle weakness. So as we go back to the Trendelberg test. So we're assessing the gluteus medius strength. Again, you ask. So if you did it during gait at the start of the examination, this is okay. However, if you didn't do it, you have to do it at this stage. You can ask the examiner that I would like to do a Trendelberg test while the patient is standing after finishing from gait. So the weakness of the gluteus medius muscle is due to possible osteoarthritis or gluteal tendinopathy.
So what I will do is kind of be off to the side so that I'm not in the way, and I'll put both of my hands on his iliac crest. And so since we're going to assess his left side, is you want to make sure that both iliac crests are level to start with, and then what you're going to do, assessing his left side, we'll have him raise his right leg up, and a negative test would be that both iliac crests would stay level. And typically you want to do this for over a 30-second time frame. So again, a negative test is that he stays level with both iliac crests, so therefore your hand would stay level. A positive test is what would happen is the right side would drop, so the contralateral side would drop, therefore your hands, and therefore his iliac crest would be unlevel. So again, one places the leg back down. To start with, is you put both hands on iliac crest. He raises his right leg to assess the left side. A positive response would be he would drop on the right side, indicating weakness on his left side and or hip osteoarthritis. A negative test, again, is both iliac crests stay level and the left and the right side does not drop. A weakness would be the right side dropping.
And finally, we check for pelvic instability. You'll be asked a question: what is the strongest joint in the pelvis? No one says pubic symphysis, because patients can walk with fractured pubic symphysis. I'll give an example. In pregnancy, the pubic symphysis is widened because so the mother, the womb, can carry the child of weight of around 3 kg or more. So the pelvis is adequate to carry the child, so it has to widen. This is why the joints at the front for widening. So to test for the sacroiliac joint, we do a test called Faber test, Patrick. It's actually a mnemonic for flexion, abduction, and external rotation. So as shown here in the picture, so he's flexing the hip, external rotated, as shown earlier during the range of motion, then abducted. And then the patient will, then the examiner will place his hand on the contralateral hip side for stabilization, and then he press down. A positive test will show if the patient develops pain from the SI joint. Now the lateral decompression test. So in a lateral decompressive position, so you press on the patient's iliac crest directly to stress the SI joint. This is the end for sacroiliac. Now finally for the pubic symphysis, it's an anterior to posterior compression. Remember when we palpate the pubic symphysis, it's the same. You palpate the pubic symphysis, but however, you press with more force. However, don't press too much. You don't want to hurt the patient, cause trouble or medical legal problems. A positive test if the patient complains of pain, let's say a pubic symphysis fracture or arthritis. So this is the end of the hip examination. Now finally, there's a common question. So what are the common questions you might be asked? You'll be asked mostly on hip. So you read the hip the hip pathologies chapter in Toronto Notes. It's one of my favorite books I studied during my 5th year rotation in orthopedic surgery, and it's incredible. So what's the most common hip dislocation? And what is the risk? What is the patient at risk of from that dislocation? Another question is, while examining the muscle function or neurovascular status, ask about the clinical significance. Let's say, for example, a sciatic nerve injury. So how do they present? Let's say this patient who had this injury or this has this hip dislocation. How do they present? Shortened, external rotated, rotated, based on the scenario. Sometimes the doctor will tell you a short case scenario. So he tells you a scenario, just the aim of, he tells you what's the nerve affected, or how do you manage it, especially in pediatrics, as you will take in a PBL case of patients who have a development dysplasia of the hip. And this is the end of the presentation. Thank you so much for your time and your attention. Wishing you all the best of luck in orthopedic examination, and stay safe. This is Khalid Al-Awadi. Thank you. Bye-bye.